Okay, I think I'm going to try to wrap this up right now. This is the 20th microbiology video, obviously because this is a very long chapter, right? Biochem was extremely long too. I had almost 2-3 hour videos for that one. But microbiology is just way too boring for me to consistently keep going. And it's just a lot of material for you to like absorb all in one shot too. So all that's left for us to talk about now are the antifungal therapy, right? And then we're going to just wrap up a little bit of the antiprotozoal things and antiviral therapy. It's really not that long of a chapter that's left anymore. So antifungal medications, I have a note here saying antifungal medications consist generally of 4 classes. Right, number 1, polyenes, which is right here, so Amphotericin B and nystatin. Amphotericin B is pretty much your big guy medication. Right, so they both bind to ergosterol molecules in the fungal cell membranes, creating pores and causing cell lysis. Right, so they basically depend on ergosterol. If there's no ergosterol, there's going to be no use for amphotericin B or nystatin. Triazoles like ketoconazole, fluconazole, all those azole medications, they inhibit the synthesis of ergosterol, right? So if you're using the rest of them are all listed right here. So that's your second general class. The third one, echinocandins, right? So all of these guys, the ones that end in fungin, right? They're antifungal medications. So they inhibit the synthesis of glucan, a component of the fungal cell wall, right? So you can see it's pointing at the cell right here. It directly inhibits glucan synthesis. The last one, your pyrimidines, or basically anything that stops nucleic acid synthesis, right? So you have your flucytosine, the only agent in this class of antifungals, converted to 5-fluorouracil within the fungal cell and interferes with fungal RNA and protein synthesis. That's the flucytosine, and we're going to see more about that. The only one that's not in this general class of stuff is your terbinafine over here, which is basically for like nail fungus. Terbinafine directly inhibits the enzyme squalene epoxidase, so you can't make squalene into squalene epoxide, right? Whereas all your azoles, they inhibit 14-alpha demethylase, which actually makes ergosterol eventually out of lanosterol. Right, so that's generally all you need to know for fungal medications. Really not that hard at all. They're pretty straightforward. And there aren't that many fungi to begin with, so it's not so hard to remember what you're going to use to treat anyone. All right, so first we have Amphotericin B right here. It binds ergosterol, which is unique to fungi, so that's good. It'll know what to go kill. Forms membrane pores that allow leakage of electrolytes. Right, so amphotericin, it tears a hole in the fungal membrane. It's also amphotericin though, because it does have a lot of bad side effects. Clinically, it's used for serious systemic mycoses, right? So really big deal infections. Cryptococcus, right? Amphotericin B, with or without flucytosine for cryptococcal meningitis. Now, let me just find the picture real quick. All right, so instead of going back and forth, I'll just keep bringing up the second book to show the picture. So here you can see from the sketchy micro image of flucytosine, right? This is Cryptococcus right here, and on the wall the medications are right there, right? So amphotericin has always been the amphibians, so all the frogs that are on the paintings, and then the guy playing the flute is supposed to remind you of flucytosine. You have to use both medications most times to actually treat Cryptococcus, right? Blastomyces, histoplasma, coccidioids, Candida, mucor, right? You have to give this medication intrathecally, right into the CSF, if you're trying to treat fungal meningitis, which generally would come from Cryptococcus for the most part, right? Cryptococcus can cause that meningitis. Supplement potassium and magnesium because of the altered renal tubule permeability. Now, a lot of these medications, the antifungal, as well as a lot of the antiviral medications, they have many effects on the kidney, right? So here what we're seeing is an effect that makes you lose potassium and magnesium, both of which are pretty critical vitamins, right? Not just vitamins, but also not vitamins at all, what am I saying? Both of which are very important electrolytes, okay? Adverse effects: fever, chill, the shake and bake effect that it can have, and you'll see that in the question. If you see a question about the shake and bake effect, is basically someone who just got started on Amphotericin B, and now they literally are presenting like they have fevers and chills, even though they don't have a cold. All right. Hypotension, nephrotoxicity, arrhythmias, rarely fatal, but arrhythmias are fatal in general to begin with, so it can kill a person. Anemia and IV phlebitis, which can be described in a question stem. IV phlebitis, right? So basically, how does IV phlebitis look? Let's say you have an IV line inserted in a human somewhere in the arm. Whatever vein you're filling with that IV line, you're going to see it's inflamed. So you could see like a red line of inflammation along the path that vein is flowing. And that's something that Amphotericin B causes. So hydration is obviously going to be very important. Anytime you have a medication that can cause nephrotoxicity of any level, you want to tell the patient to drink a lot of water, right, all the time, not just when they're taking the medication. All right, so here's an AMBOSS question related to amphotericin. It says, a 43-year-old man is brought to the emergency department because of fever, cough, pleuritic chest pain, and dyspnea. 2 days ago, he returned from a construction site along the Mississippi River, which is supposed to tell you what fungus he might have been exposed to. Abdominal exam shows a palpable spleen, and X-ray shows diffuse reticulonodular infiltrates. Therapy with the drug that binds ergosterol is initiated. This patient is most likely to experience which of the following adverse effects? Right, so now they tell you what the medication is because they tell you what it does. Right, it binds ergosterol. Only 2 medications need ergosterol for them to work, and that is Amphotericin B and nystatin, the one right after. Those 2 medications need ergosterol, as you can see from the picture right here. Right, they need ergosterol because what they do is they actually use ergosterol to create pores so that you would have holes in the cell membrane and die. That's how it kills the fungus. So because the patient was put on amphotericin, any one of these adverse effects would be the correct answer choice, or the fact that you can lose K plus and magnesium. Right, you can lose potassium and magnesium, and that's going to be problematic. Alright, so that was the answer right there, hypomagnesemia. The other answer choices didn't really fall into place relating to amphotericin B. This patient's presentation of pneumonia and splenomegaly in the setting of a recent travel to the Mississippi River Valley suggests histoplasmosis. Right, so you remember, you have to memorize those tables, right? Those graphs, or what am I saying? The maps, right? So we're saying that this guy was in the Mississippi area, right? And the Mississippi area is all histoplasmosis. Right, so very critical to. Now, of course, this question wasn't about, it wasn't about what bug caused the infection. They weren't trying to ask you that. But if they were, you didn't really have any information other than Mississippi and the fact that he has pneumonia, which pretty much all of them cause. So just off of Mississippi, you have to remember Mississippi is related to histo. Right? Mississippi is histo. Eastern U.S., which is pretty much where I am, like New York and stuff, that's going to be blasto. And then coccidio is in Cali. Right? It starts with the C. Coccidio is in California, but more so not just California, it's southwestern U.S. Right? So you have to remember the map for these guys: histo, blasto, coccidio. All right, let's see. So that was really all that happened. Now, in this AMBOSS question, they also explained how the hypomagnesemia happens, and it's not very critical for you to know this now. But later on, when you do renal, when you look at the Barter, Gittleman, and all of those syndromes, a lot of them have things like hypomagnesemia, hyperkalemia, stuff like that. They often don't make any sense. They don't make any sense why they happen, right? So this explanation kind of shows why it happens, but you don't really need to worry about it right now, so I'm not really going to dive into it right now either. But I will come back to it much later on. Renal is pretty much like one of the last 2 chapters, but I will come back to it much later on. I actually put this explanation there too because it was a really good way to see how a person can lose magnesium due to some kind of alterations in the kidney, in the renal tubule. The next medication, nystatin, same kind of thing, right? Same as amphotericin B. Both require ergosterol to do their job. Topical use only, as it is too toxic for systemic use, right? So these 2 guys are really bad medications. However, when you have candidiasis, you do the swish and swallow. So you literally swallow it, you don't spit it back out. Swish and swallow. Topical for diaper rash or vaginal candidiasis, which are The diaper rash thing is a very common pediatric thing. It happens all the time. Vaginal candidiasis is also pretty common, right? So not the rarest things on earth, and nystatin is a very important antifungal medication for all of that. Flucytosine, as we just saw, right, for not for Cryptococcus, right? Cryptococcus, you use Amphotericin B with or without flucytosine, depending on if the person has cryptococcal meningitis, right? And and it has to be given intrathecally if there is meningitis. You give it right into the CSF, not systemically, not as an oral pill. Right, so flucytosine over here, this inhibits DNA and RNA biosynthesis because it's flucytosine. It actually becomes 5-fluorouracil by cytosine deaminase. Right, 5-fluorouracil was a medication that was already discussed a couple times so far. It's been discussed in biochemistry. I think we talked about it a little bit in immunology, and then we'll see it again in other discussions regarding cancer and stuff. Right, so it inhibits DNA and RNA biosynthesis, so it basically inhibits cell division and replication. Alright, clinical use: systemic fungal infections, especially meningitis caused by Cryptococcus, in combination with Amphotericin B. The only bad side effect it has is a pretty predictable one, and that's the bone marrow suppression. Right, this is a snippet from the Cryptococcus image showing you the person in the wall playing the flute to remind you of flucytosine. Right, and then you have the amphibians for Amphotericin B. The flute also tells you one more thing, right? Because in the next page, we're seeing all the azoles, right? It's not the next page. The next medication are all the azoles. So you have a bunch of different ones. Clotrimazole, Fluca, isavuconazole, itraconazole, ketoconazole, the most common one that everyone knows about, miconazole, and voriconazole. So all of them, they inhibit the synthesis of ergosterol, right? So you don't even make ergosterol now by inhibiting P450. Right, so now it's one of the easiest medications to remember when it comes to P450 alterations. The mechanism of an azole is to inhibit P450, so of course it's one of the medication types that inhibits P450. Right, so you have to remember that the mechanism of action of azole is its own adverse effect as well. Right, and then ketoconazole is notorious for the gynecomastia that it can cause by testosterone synthesis inhibition. But what I wanted to get to was the, let me see where it is, the fact that it breaks down over here, right? So now they're going to tell you very specific ones that you can use. You can't use any azole for any fungal infection. It doesn't work like that, right? So fluconazole for chronic suppression of cryptococcal meningitis, right? So it's actually fluconazole for Cryptococcus. So you don't just give any azole, because there are remember in Sketchy Micro, to talk about azole medications, it was all these pine cones, right? They put a bunch of pine cones in the picture. If you saw pine cones in the picture, you knew that you could treat the fungus with an azole medication, right? But pine cones don't really tell you which azole medication to use. So when you come down to Cryptococcus right here, right, you can see the pine cone on the wall right there on the drawing. Let me actually put that entire thing so people will know. I don't need to just put, let me see, that's good enough like that. Yeah, I'm gonna add the whole thing. Right, so okay, because now the flute actually helps you remember multiple things. So which azole will you give? You're going to get fluconazole, right? You're going to get fluconazole and flucytosine and then Amphotericin B as well, depending on how severe the cryptococcal infection is, right? So there's that, right? So you got all the medications down for Cryptococcus, not going to have an issue with that. And it's not that hard of a fungus to work with either. So that was fluconazole, that's done. So we're done with Cryptococcus, alright? Itraconazole may be used for pretty much all of the other guys, right? So you have blasto, histo, coccidioid, and then Sporothrix schenckii, the one that was related to a rose thorn, alright? clotrimazole and miconazole are for topical fungal infections. Now, the other guys can also be used for topical fungal infections, so this isn't that important. Voriconazole is important, and Sketchy Micro actually added a snippet to their original drawing because they wanted you to remember that. So this is Aspergillus right here, right? And we've already done all these pictures when we were doing previous videos and going through all of this stuff. For Aspergillus, the main thing was this tornado when it comes to medications, right? This tornado, and you don't want to call it a tornado, you're going to call it a vortex, right? So the vortex with all the pine cones in it reminds you of the fact that you can use azoles, but not just any azole. This is voriconazole, all right? Voriconazole, and that's what's significant when it comes to Aspergillus, right? So they tell you here voriconazole for Aspergillus and some Candida, but just don't forget voriconazole for Aspergillus. I never forgot it after looking at that Sketchy Micro video, but you know, it's not the easiest thing to remember either if you haven't really applied it or if you haven't really seen the video or the picture doesn't work for you. So that vortex in that picture is actually for voriconazole. The last one is isavuconazole. This is pretty much the longest name of all of them, and it's the strongest, right? So you use this for serious Aspergillus and mucor infections, right? Mucor can be really dangerous as well. And that's it for the azoles. Remember the P450 stuff, right? They inhibit P450. Terbinafine, as I told you, is pretty much for nail fungus. This is a very strong medication and very helpful medication. It does the job almost immediately. Anyone has nail fungus, you get them on terbinafine. I had a patient who came in with fungal nail infection, right? So he had nail fungus. He was 55 and he just wasn't taking care of his health that well. Right? He was also a little immunosuppressed because he was going through some chemotherapy at the time. He's doing fine now, right? I still hear from him because I actually became like family with him. But when he came in, my doctor gave him terbinafine, and you know, within the next, I think I saw him after 3 weeks. He came back again. So in those 3 weeks, he was perfectly good to go. Everything was fine, right? You do have to get your liver tested regularly, so you have to check for liver enzymes because it is hepatotoxic. Other than that, there was nothing else wrong. All right, so very good medication when it comes to taking care of dermatophytoses. Echinocandins are all your fungin guys, right? That's the fungin medications that we saw. They inhibit cell wall synthesis by actually inhibiting the synthesis of beta-glucan. And that's what I was showing you guys when we first started this video right now. And this is also good for invasive aspergillosis and candida. That's it, right? It causes flushing due to histamine release. I've never really seen a question on echinocandins that was confusing. The only question you're really going to get on echinocandins is whether or not you use it. It'll be in your answer choices. You pick it if the question is telling you the mechanism they want you to go with, or if the question is telling you it's invasive aspergillosis and that's the best medication for it, okay? Otherwise, you would pick whatever else is a better medication. Don't just pick it because you see it. Griseofulvin is also a really interesting medication. It's been discussed a little bit before. So this guy was discussed a little bit in biochemistry when we were talking about the cellular stuff, because it actually interferes with microtubule function, right? It disrupts mitosis by messing around with microtubule function, and microtubules play a very integral role in mitosis. It deposits in keratin-containing tissues like the nails, right? Oral treatment of superficial infections. It also inhibits the growth of dermatophytes like tinea and ringworm. But it's very rare to actually use griseofulvin for any of these things for the most part. I mean, there's usually better topical ointments that'll do a quicker job. And griseofulvin is also pretty dangerous, right? So it's teratogenic, which means you can't give it to pregnant women. It's carcinogenic, which is a risk you don't really want to take, right? People are always okay with smoking cigarettes no matter how carcinogenic it might be. But if a medication is carcinogenic, no one wants to touch it, right? And of course, griseofulvin increases or upregulates cytochrome P450 and warfarin metabolism. Alright, so increase P450 activity, increase warfarin metabolism. So it's not really a good medication in that aspect. This medication will just be there as one of the answer choices to just make you think like, oh shit, is that the answer? Otherwise, rarely is griseofulvin actually the correct answer. Then they go on to antiprotozoal therapy, right? So antiprotozoal therapy, you have pyrimethamine for toxoplasmosis, pyrimethamine, Suramin and melarsoprol for Trypanosoma brucei, right? And there was a difference between the two medications as well. You had to remember, when you would use each one. So let me see, suramin and melarsoprol. Right, so this is all your protozoal stuff now. We're looking at protozoa. We already talked about the ones that you could treat with metronidazole, right? We talked about that. This one with the knitted sock, remember the knitted sock that he's carrying, right, is for nitazoxanide for cryptosporidium. Here's your toxo. So toxo means sulfadiazine and pyrimethamine. We already talked about the sulfadiazine part. Now they're talking about the pyrimethamine. And here we have our Trypanosoma brucei guy, right? So suramin and melarsoprol, and you have to remember that suramin is for the serum, right? Suramin is for the serum. It's for the blood-borne disease, and melarsoprol is more like melatonin in the sense that melarsoprol is for the CNS penetration that Trypanosoma brucei can have. So very important to remember that, because they're going to ask you about two different medications, and you have to be able to pick out what medication you need to give to your patient. And then nifurtimox for Trypanosoma cruzi. Remember the benznidazole and nifurtimox, right? Cruising in my Benz with my fur coat on, the fur coat for nifurtimox. Sodium stibogluconate, that was also discussed in the, let me see, let me move this into here so they're in the same tabs. Okay, alright, so we're looking at sodium stibogluconate. So here we have the nifurtimox stuff, right? Benznidazole or nifurtimox, either one is fine to treat Trypanosoma cruzi. Leishmania, right? He's giving them these little steaks, right? He's offering a steak to the mummy, and we talked about this image already as well. That steak is supposed to remind you of stibogluconate, right? For leishmaniasis, sodium stibogluconate. It's a salted steak. Anti-mite and louse therapy is just a very annoying question. It can obviously pop up, and what they're going to try to do is they're going to ask you about the mechanism of action through which these medications work. They'll more than likely tell you the medication and then be like, what did it do? So for example, if they tell you permethrin, then that inhibits sodium deactivation, right? So if you have sodium channel deactivation, that's going to cause too much neuronal membrane depolarization. Malathion is actually an acetylcholinesterase inhibitor, so you're going to have too much acetylcholine in the mite or louse, whatever you're trying to treat. And lindane, one that almost no one really tends to remember. Lindane blocks GABA channels. I never remember lindane. I've never seen it in a question. I've never actually known anyone that used it or seen it being used or anything like that. So lindane blocks GABA channels, causing neurotoxicity. And the thing they have here to memorize it, so it says treat PML, pesty mites and lice, with PML, permethrin, malathion, and lindane, because they nag you, right? So treat these pesty mites and lice with permethrin, malathion, and lindane because they nag you, and the nag helps you remember sodium, acetylcholinesterase, and GABA, all three of which are pretty much blocked, right? So they don't work in terms of channels. All right, then you have your chloroquine. Chloroquine, really big deal. This medication was discussed when we did all the malaria bugs, and you had all your different queens in this picture. 1, 2, 3, 4, 5. Your artist for artesunate, right? 2 different artists over here. All these queens were supposed to remind you of which queen you're supposed to give to treat different forms of malaria, right? Because there's various plasmodiums that you have to work with. We had your Plasmodium vivax and ovale, falciparum, and malariae, of which pretty much the worst one and the most problematic one was falciparum. Right? Falciparum is very severe, irregular fevers, parasitized red blood cells, occlusion of capillaries in the brain, kidneys, and lungs. Right? So very problematic. Oh, God. Okay. I hate yawning. I hate yawning when I'm streaming, but this shit is just... I think I haven't slept enough. No, I slept enough. This is too boring. There's like nothing interesting in teaching microbiology. Yeah, so chloroquine blocks detoxification of heme into hemozoin. So one of the ways that chloroquine actually works is by increasing the amount of heme that's there, right? So when you have a lot of heme, all that heme is actually going to be toxic to Plasmodium itself, right? Heme is toxic to the various plasmodia. Treatment of plasmodial species other than P. falciparum, right? Frequency of resistance into P. falciparum is too high. Alright, so you can't really give chloroquine for Plasmodium falciparum. Resistance is due to membrane pump that decreases intracellular concentration of the drug. Treatment of P. falciparum is with the artist, right? So remember in this image you have a bunch of queens and you have two different artists. You have this artist over here that's drawing that queen, and then you have this artist over here that's drawing this queen, right? And that's because they actually go together, right? This artist with your Atova queen, right? So this is Atova queen that you also use for Babesia, and then this artist over here with the other one, and they tell you here, right? So you have your Artemether with lumefantrine and Atova with proguanil, right? So you have your Atova with proguanil. Atova with proguanil is a whole different thing. This is a perfectly fine mixture that you can use for almost all of them. It works for P. falciparum as well. Here it is, this one, artesunate, right? So artesunate is the other medication that you can add in to any of these regimens, right? So you have your Artemether, lumefantrine, atovaquone, proguanil, artesunate, quinidine, right? Quinidine is also one of the queens, basically. All of them are queens because these medications have this ending called queen. The last sentence is pretty important too. Life-threatening malaria, you just give quinidine. Right, quinidine doesn't really always tend to work either. There are cases now in questions where there's resistance to quinidine. So artesunate, if it's also there, then you can definitely go ahead and pick it. Yeah, you can't skip it if you're studying for step 1. I just wish I could have skipped it. I really don't like tutoring it either. Alright, so side effects of this thing are pretty easy to remember as well, because if you remember the mechanism, side effect falls into place. The mechanism is increasing heme. So remember with all the heme toxicity issues when you do heme onc, when you have too much heme and the person goes to shower, for example in, what's the disease called? The disease with too much red blood cells. Help me out, guys. What is that condition where you're making too many? Oh, polycythemia. In polycythemia vera, right, you also have the same kind of issue. When you go to take a hot shower, you start feeling very, very itchy. That kind of pruritus thing. So that's what you're seeing here too. That's basically all that's happening here. Right, the retinopathy is not that big of a deal. It doesn't really show up in questions, but the pruritus will definitely show up. So patients taking any kind of queen medication, any of these guys really, will lead to pruritus because they have too much heme in their blood. Alright, Antihelmintic all came from this one picture that we did way in the beginning when we were doing all the helminths. So pyrantel pamoate, ivermectin, mebendazole, praziquantel, and diethylcarbamazine. Remembering which medication you use for who is really just from that picture for the most part. I haven't really thought of any other way to memorize it. Let me see. Almost fit. Okay, so in this image, when we did it originally, we talked about a bunch of the guys, right? So this guy in the back with the red eyes, he's actually showing you Onchocerca volvulus, right, which is going to cause the river blindness, right? So you treat it with ivermectin, and that's why this symbol back here about a river, I forget what the symbol is actually about. Yeah, it's not clear here, but they used that river symbol before too, and it's really just there for the river information. And every time you see river stuff in a sketchy micro image, is actually for ivermectin. You could call it rivermectin, ivermectin. So that's what you use for Onchocerca, ivermectin. Wuchereria bancrofti is this witch over here, right? You could tell from her pants that Wuchereria bancrofti basically causes elephantiasis. Right, the treatment for elephantiasis or Wuchereria bancrofti is diethylcarbamazine, which is just depicted with a magazine. The same magazine that this guy over here is reading, right? So he's Loa Loa. He's actually Loa Loa. He causes transient angioedema. Yeah, he causes transient angioedema, and he's also treated with the same shit, diethylcarbamazine. That's it, right? Same thing you would use for both of them. Albendazole also works, and albendazole is always shown with the bended, the bent legs of these seats, right? So you can see the bent legs of the chair itself. So that's albendazole as well. The other guy over here, the one that's sleeping, he's the wolf. The wolf guy depicts Toxocara canis. Canis in Latin, for like a canine, right? So like a dog and stuff. So this is from contamination of food with dog or cat feces. Treat with albendazole, depicted by the bent metal legs of his chair, shared with Loa Loa. And that's really all there is to it. I can't remember what this vampire guy was for. I'm not sure what I'm forgetting. Yeah, I can't remember what the vampire guy was for, but he was definitely one of the guys too. I'm not sure why his note is in there. Let me go back and check. The wolf fly, the wage, the wolf guy. Oh yeah, the Dracula guy. Okay. Contains copaz. Oh yeah, okay. The reason I didn't write him in that other image is because you don't actually need a medication to treat him, but I'm going to put it in anyway because it's in the image, so why not? But the Dracula actor, these are all actors by the way, right? They're all actors because they're on like a play set. So the Dracula actor, he's for Dracunculus medinensis, an infection that comes from water copepods, so he's drinking water. And these worms basically just can enter through the skin and cause ulcers, so that's why he has like untied shoelaces and stuff. And the only way to fix this is to really just carefully extract the worm by spinning a rod or stick where you're wrapping the worm around it, and then you just take it out. You have to go real slow and easy, because if you go too fast or you rush, you can actually break the worm, and then the remainder portion of the worm will just go back in, and it might never actually come out. So that's going to be really problematic, and I'm sure there have been many cases where it did break. So you don't want to be responsible for something silly like that. So be patient, pull it out real slow and easy. So that's what you're seeing with his untied shoelaces. That's all that's wrong with him. Dracunculus medinensis. All right. Finally, we're down to antiviral therapy. Now, antiviral therapy is very high yield because HIV is high yield, and all the other viruses are very high yield and super testable, right? Let's see. So the left half of this is all HIV antiviral therapy. So you have your reverse transcriptase, right, doing its job, integrase, protease, anything that causes fusion, right? 4 different groups. So you have your NRTIs and NNRTIs. NRTIs are the most annoying medications because they have these like 3-letter name acronym things that you have to know. Lately they've gotten a lot better. Like, it was kind of annoying back in the day when I took step 1, whereas Ziduvudine was actually AZT. So now Ziduvudine is correctly ZDV, which makes sense, Abacavir is ABC, Didanosine is DDI. So far so good. Emtricitabine being FTC doesn't make any sense. Lamivudine being 3TC doesn't make sense. These 3 right here in the middle don't make any sense. Tenofovir is TDF. Sure, you can live with that. And you do have to know the 3-letter acronyms. They can actually just give you that as an answer choice in your questions, or they could be talking about it specifically, one of these using their 3-letter acronym. And if you don't remember which one it is, it can become problematic, but it will be a really hard question anyway, so it doesn't even matter that you didn't understand it. Just get it wrong. Like, literally there's no hope at that point, because if they're trying to talk about one specific medication, it's really hard to remember the side effects of any one of them specifically. What they all do generally is not going to be that bad, so we'll get there. NNRTIs are special only because these medications cannot be used for HIV-2. Everything else, generally speaking, does work for HIV-1 and 2, but NNRTIs you cannot give to HIV-2 infections. Right? There's actually a really big difference between HIV-1 and HIV-2, which is why it's really important to figure out if a person has HIV infection, which one is causing it. Is it HIV-1 or HIV-2? because you approach both treatments differently. And if you haven't actually spent time trying to learn about the two differences and figure out what, how they're different, Medscape has a really good article right here. Medscape has a really good article just talking about it, right? If you search Medscape HIV-2, you'll find a bunch of information about HIV-2. And as they talk about HIV-2, they also compare it to HIV-1. And so you get to key points, and then you see a table of all the different kinds of medications, right? And they tell you what medications you can use for different guys. And NNRTIs, right? They tell you NNRTIs block HIV-1 reverse transcription through a specific binding site that is not present in HIV-2. This class of drugs will not be effective against HIV-2. So you cannot give NNRTIs to HIV-2 infections. And remember, step one in medicine, they want you to be doing research. So, if you're not looking things up to make sure you learn it, keep yourself up to date and stuff, you can definitely fall prey to questions related to these topics. So it's always good to make sure you know. And the reason you would go ahead and search this is because in the book itself, they tell you that some of these medications work for HIV-1 and some of them work for HIV-2. So very important to make sure you check which is for which. The book doesn't actually go into detail about that. Fusion inhibitors are a pretty high yield thing, right? So you have your Enfuvirtide, which is actually for fusion, as you can see here, right? And F for fusion, F for 40, right? So GP41. You have to remember which receptor allows this kind of penetration to occur. Whereas Maraviroc, I always think of Maraviroc as for docking, right? Like landing. So here the virus is just now docked on the membrane, and that is, the docking thing is attachment, and that's Maraviroc, and that's going to be GP120. All right, so GP41 for fusion or penetration, GP120 for attachment or docking, right? Maraviroc. Integrase inhibitors, they all have GRA in the name, so you can remember integrase, right? Gravir. Doesn't matter what gravir it is, as long as it ends in gravir, just remember it's an integrase inhibitor. It basically stops this DNA integration of whatever reverse transcription was done. All right. Protease inhibitors all end in NAVIR, right? So thank God for that. Thank God for that, like, synergy of naming and not stuff like what's happening with these guys. I don't know why NRTIs are named in such a messed up fashion, right? It's just really unnecessary. But protease inhibitors are all ending in NAVIR. Integrase inhibitors all end in GRAVIR. So what do protease inhibitors do? These guys mess around with translation, right? So what does HIV do? It enters, it uncoats, right? It uses reverse transcription to take all of that RNA and make DNA. Then that DNA gets integrated into your DNA, and then it uses your shit to do more transcription and make mRNA, and then you now are translating proteins that HIV-1 or 2, HIV, made you translate, right? So HIV efficiently brought in mRNA that you are now making yourself, and that's so messed up, right? So a virus just changed around what you are going to go ahead and code for, and it basically hijacked your cells, it hijacked your body in a sense, right? So now you're translating and you're making all these proteins. Protease inhibitors, or protease inhibitors in general, what they do is they'll go ahead and just mess around with this translation, right? So everything that's being packed and assembled is going to get destroyed, right? So the proteolytic processing gets destroyed. Because remember, when you make a protein, it's really, really, really long. Then a protease is going to come and cleave it and make it into the correct active form. If you have protease inhibitors, you're just going to end up making a really, really long non-functional protein that your own body is just going to destroy because it looks like it's a waste of space. If all goes well for HIV, then you'll successfully make whatever it tells you to make, and then you'll release more viruses that are now going to go infect more of your cells. So that's all of HIV stuff right there. Other antiviral therapies, such as for all the different DNA and RNA viruses we looked at other than HIV, that includes things that stop protein synthesis, such as interferon alpha. Right? Remember how interferon alpha stops things. You have to remember how it interferes with protein synthesis, and we're going to get there. When we talked about interferons earlier, we talked about interferon being something similar to a double-stranded RNA. So what a double-stranded RNA does, and you always get experimental questions about double-stranded RNAs. Excuse me. So double-stranded RNAs, they're going to go into your body, right? They're going to become single-stranded RNAs, and then they're going to combine with your RNAs, thereby not letting them be translated. Right? So that's how they interfere with protein synthesis. And you give interferon alpha for hepatitis, HBV and HCV. Right? They bind over here at the PKR. We're going to see more of that when we actually get to interferon alpha at the bottom. Other than that, most viruses, they're going to bind, they're going to get endocytosed, they're going to enter, right, because they have the correct proteins up there to be able to enter. And then they'll try to get an envelope, or they already have an envelope, stuff like that. After they already have an envelope, that's the only way they can enter, right? This is an envelope. With that envelope, they were able to dock, and then they were able to enter. Then the envelope gets destroyed, and they uncoat, right? And uncoating is actually stopped by amantadine and remantadine, which are no longer used for influenza due to increased resistance. All right, so that's some good news. So if you see amantadine or amantadine in your answer choices, don't pick it if there's another answer choice that's better. All right, you still need to know about amantadine or amantadine because they've been used for such a long time, and some places on Earth do still use it, but it's not a good idea. It doesn't work anymore. Influenza has become resistant to it. So after uncoating, you release whatever nucleic acids you had. That nucleic acid has to replicate, right? So 1 became 3 over here. To stop that, you have nucleic acid synthesis inhibitors, right? So now you're going to have a bunch of nucleic acid analogs. Guanosine analogs are your acyclovir and ganciclovir, right? A bunch of different cyclovirs. All the cyclovirs are pretty much your nucleic acid synthesis inhibitors. You use different ones for different viruses, and we're going to get to that soon enough. Viral DNA polymerase inhibitors are basically the really, really strong version of medication. So if you get a question where acyclovir, ganciclovir, stuff like that, they're not working, then you can go ahead and pick foscarnet as your answer or cidofovir as your answer. You're not going to have both. Both options won't be there. Guanine nucleotide synthesis, ribavirin. We've talked about ribavirin many times. Great medication that you can give to both respiratory syncytial virus or hepatitis C. Right, so that's a guanine nucleotide synthesis inhibitor. If you don't do that either, then the replication then leads to translation, you do protein synthesis, and then you now make more viruses that you're going to go ahead and release. However, with the flu, right, with influenza A and B, good news is even after getting to this point, you can stop things if you're able to get to oseltamivir or zanamivir in time. These are neuraminidase inhibitors. Remember, influenza is neuraminidase Na positive. If you stop Na, then you're unable to release the variant progeny, right? So all the new viruses you made will get stuck inside the cell, and they'll never get released, and then everything's going to be all right, and the patient will recover much quicker from the flu. However, it's been too long. If it's been too long, so if it's been over 48 hours, over 72 hours even, then by that time the variant have already been released. So giving oseltamivir, zanamivir won't really help as much. So the first medication they talk about is that oseltamivir, zanamivir. In America, it's actually called Tamiflu. Right? Tamiflu is the medication you order real quickly for any child, anyone that came in with the flu, and you just start, helping them recover. It inhibits neuraminidase, decreasing release of progeny virus. Treatment and prevention of both A and B influenza. Begin therapy within 48 hours. All right, that's really all you need there. Now, acyclovir, famciclovir, and valacyclovir. Val is for availability. That's what they add val for, right? So if you see any medication and you see another medication that has the same name but val in front of it, it basically means that it has better oral bioavailability. So in essence, it's a better medication, right? All of these guys are guanosine analogs, monophosphorylated by HSV or VZV thymidine kinase, right? And that's a pretty common theme here. So what you're going to see is some thymidine kinase, some viral kinase is actually going to have to activate the medication for the medication to go kill that virus, all right? So thymidine kinase is going to activate it, but it will not be activated in uninfected cells because they won't have HSV or VZV thymidine kinase. So that actually is a good thing because now you're targeting exactly infected cells, right? So fewer adverse effects. The triphosphate is formed by cellular enzymes, preferentially inhibit viral DNA polymerase by chain termination. Perfectly fine, right? So clinically, it's used for HSV, both 1 and 2, as well as varicella zoster virus. Weak activity against Epstein-Barr. It doesn't really even work against Epstein-Barr. And it doesn't work against CMV either. So you do not pick one of these 3 medications for Epstein-Barr or CMV. It's just used for HSV-induced mucocutaneous and genital lesions, as well as for the encephalitis, right? So encephalitis was HSV-1, genital stuff was for HSV-2. Prophylaxis in immunocompromised patients, no effect on latent forms of HSV and VZV, which is pretty obvious. If you just have latent infection, it's not active, but it's just going to be there, and there's no way to get rid of it. So once you have herpes for life. Whether or not it's active depends on your immune capabilities. Valacyclovir is a prodrug of acyclovir and has better oral bioavailability. So they're basically just adding val at the beginning of the name to tell you that it has better availability. For herpes zoster, use famciclovir. And this was never really hard for me to remember because fam has, it's like family, and herpes zoster is generally going to happen to a family member, like an elderly person in your house who is going to have reactivation and get shingles or something, right? So that was how I reminded it to myself, and I never really forgot. What I don't remember, and I just remembered it now when I saw it, is that these guys, these guanosine analogs right here, acyclovir, all the cyclovirs, they can cause obstructive crystalline nephropathy and acute kidney injury if the patient isn't drinking a lot of water, right? And there are people like that on earth that don't drink a lot of water. There are people that don't even like water, so all kinds of weirdos. Can't do much about it. But when you give this medication to your patients, you have to urge and tell them why, so that they're further encouraged to do so. You have to urge them to drink water. They can't just stay dehydrated all the time, especially if they work out a lot or if they have some kind of job that makes them sweat a lot. They need to have a lot of water in their system. And of course, any issue with the thymidine kinase that's supposed to activate it, if there's an issue with that thymidine kinase, then the medication won't work. So that's the mechanism of resistance. Ganciclovir is the one you use for CMV, right? Because remember over here we just said it doesn't work for CMV, it doesn't really work for Epstein-Barr either. So ganciclovir is what you use for CMV. It's also a guanosine analog. It's actually activated by the CMV viral kinase, and it inhibits viral DNA polymerase. So it does the same exact thing as all these other cyclovirs up here, but ganciclovir is specifically for CMV. So you can use it for CMV, especially in immunocompromised patients. Valganciclovir, again, better availability, right, is a prodrug of ganciclovir that has better oral bioavailability. And of course it causes bone marrow suppression, right? Now that's different from up here. We didn't see adverse effect of bone marrow suppression with these guys up here. But ganciclovir can cause bone marrow suppression, right? More toxic to host enzymes than acyclovir. So very important to remember the bone marrow suppression here. Foscarnet and cidofovir are your big guys, right? They can pretty much help with almost any viral infection. Foscarnet is a viral DNA RNA polymerase inhibitor and HIV reverse transcriptase inhibitor, so you can also give it to HIV patients. Binds to the pyrophosphate binding site of enzyme, does not require any kinase activation, right? Because it's a big guy, so he doesn't need a kinase to turn him on and make him active. He's just active, right? Same thing for cidofovir too. It inhibits viral DNA polymerase and does not require any viral kinases. And oftentimes questions will tell you that a medication was used, it does not require a viral kinase for it to work. What medication was it? And you have to know, all right? Clinically used CMV retinitis in immunocompromised patients when ganciclovir fails, and you can also give foscarnet to acyclovir-resistant HSV. Adverse effects. Remember I was saying earlier that a lot of these medications have nephrotoxicity, right? Renal issues. We already saw up here obstructive crystalline nephropathy. Now foscarnet is really bad. Nephrotoxic, can cause a lot of electrolyte abnormalities, and those abnormalities can lead to seizures. So someone just starting off foscarnet right now can end up getting seizures because of the electrolyte abnormalities. So you have to make sure that that's pretty much monitored, I guess. Foscarnet, although it doesn't require a viral kinase for it to turn on, the way foscarnet works is that it targets a polymerase, right? DNA or RNA polymerase. So if that polymerase is no longer working or no longer looking the same as it's supposed to, right, a mutated DNA polymerase is a mechanism of resistance. At which point you would go give cidofovir. Cidofovir doesn't really have a similar kind of issue. Cidofovir is also used for CMV retinitis in immunocompromised patients and acyclovir-resistant HSV. Pretty much literally foscarnet and cidofovir are the same exact medication. Right, and here we have an AMBOSS question. 45-year-old man comes to the emergency department with fever, non-productive cough, and difficulty breathing. 3 years ago, he underwent lung transplantation. A CT scan of the chest shows diffuse bilateral ground glass opacities. Pathologic exam of a transbronchial lung biopsy shows several large cells containing intranuclear inclusions with a clear halo. So at this point, it's extremely obvious what's happening to this patient. Like, you should know what's happening. He got a lung transplant, and now he has ground glass opacities, which is pretty much pneumonitis or pneumonia, right? And they're seeing intranuclear inclusions, right? So owl eye inclusions, basically, and the owl eye is for sight. Sight has to do with cytomegalovirus, CMV, right? That's how you think about it. That's how you approach it. So this patient probably has CMV from the lung transplant. He is subsequently treated successfully with another medication. Treatment with ganciclovir fails, then they give him another medication. This drug does not require activation by viral kinases, right? And also has known in vitro activity against HIV and HBV. So now, this information they just gave you, the fact that the drug does not require viral kinases, not requiring viral kinases means that it's either foscarnet or cidofovir, and they tell you that it has in vitro activity against HIV and HBV. That is only foscarnet. Right, foscarnet, remember, it also works on HIV reverse transcriptase, so you can give foscarnet. So they must have given foscarnet to this patient right here. The patient was most likely treated with what drug? Foscarnet, and that's it. Right, this lung transplant recipient has CMV pneumonitis because of the ground glass opacities and large owl eye inclusion bodies, which is resistant to ganciclovir. Right, ganciclovir is the correct medication for CMV, but it doesn't mean ganciclovir will always fix CMV. So when it doesn't, you can give foscarnet or cidofovir, and here they described that they gave foscarnet. Okay, so cidofovir could have been an answer choice in this same question as well, but you can't pick it because this question is literally about foscarnet. Now we're looking at HIV therapy, right? So that's the last thing before we finally finish microbiology for once and for all. HIV therapy, right? HAART, now they just call it ART, right? Antiretroviral therapy. I think it used to be highly active, HAART. So it was HART before, now it's just ART, antiretroviral therapy, often initiated at the time of HIV diagnosis. The strongest indication for patients presenting with AIDS-defining illness is a low CD4 count of under 500, or a high viral load, which are the two things you're supposed to look for when you're diagnosing HIV. Regimen consists of 3 drugs to prevent resistance. Right? So the antiretroviral therapy, ART, always has to have 3 medications or more. They say using 2 NRTIs and preferably an integrase inhibitor to stop this stuff from being integrated into your DNA. All ARTs are active against HIV-1 and HIV-2 with the exception of NNRTIs. So now, after reading this sentence is when you were supposed to go do some research and figure out, which HIV is affected by which class of drugs, because you can actually get a question on that. But not just because of questions, this is actually relevant to you as a physician. Right, so I'm going to tell you that stuff because I actually did some research on it, but you can gladly go look more about it. Go look more up about it. So the first thing you have are your NRTIs, right? So competitively inhibit nucleotide binding to reverse transcriptase and terminate the DNA chain because of a lack of the 3' hydroxyl group. And then they start breaking down specifics about each one of these. They tell you that tenofovir is a nucleotide, right? And we talked about the difference between what a nucleoside and a nucleotide is when we did biochemistry. This is a nucleotide. The others are all nucleosides. All need to be phosphorylated to be active. Okay, so that's not so bad either. Then they tell you about zidovudine. ZDV can be used for general prophylaxis and during pregnancy to decrease risk of fetal transmission. So zidovudine is one of the most important NRTIs on this entire list. Right? You can give it to a pregnant woman to reduce the chances of the baby being born with a high viral load. Okay, that's it. Bone marrow suppression can be reversed with granulocyte colony stimulating factor and erythropoietin. Peripheral neuropathy, lactic acidosis, anemia, and pancreatitis are all your side effects. So now you see pancreatitis. Didanosine can cause pancreatitis. That's your other guy that you have to remember, right? So zidovudine for pregnant people, didanosine for pancreatitis as a side effect. That's the stuff you need to know for your answer choices. Abacavir has this one weird thing that I think both UWorld and AMBOSS had a question on. Just because it's a silly little topic, they're going to pick on it. So ABC over here, abacavir is contraindicated if the patient has HLA-B 5701 mutations. Because these patients with the HLA-B 5701 mutation, they have hypersensitivity. So all in all, just never give abacavir to anybody, right? Because there's many other options. So I don't even see the significance of really trying to learn that, but you know, they put it in the book. They obviously want to make your life harder. Clearly there isn't enough topics in the book already, so that's that. So yeah, if you see HLA-B 5701, abacavir cannot be given to that patient. NNRTIs block HIV-1 reverse transcription through a specific binding site that is not present in HIV-2. So NNRTIs will not be effective against HIV-2 due to a Y188L polymorphism. That's what they explained on that link I was showing you guys just a while ago on Medscape. Alright, so this includes 3 medications that don't end in the same thing. However, it's okay. NNRTIs and NRTIs are really dumb names. They all have really stupid names that don't end in the same ending. So if you see them, you just know, it's an NNRTI or NRTI, and that's it. So, you can actually have confusion between these two groups of medications because you might not remember on your test when you see Delavirdin, is it a double NRTI or a single NRTI? There's really no easy way to do it, alright? So, also, this is the worst one of all of them because at least most of these guys up here end in -dine, right? And so does this. So it's really easy to mistake Delavirdine to be an NRTI, but it's not. Delavirdine, efavirenz, and nevirapine are all double NRTIs. They bind to reverse transcriptase at different sites from the NRTIs. They do not require phosphorylation to be active. And side effects include rash and hepatotoxicity, vivid dreams and CNS symptoms with efavirenz. Alright, so efavirenz, you can write efavirenz with 3 Z's. Alright, so if you write it as efavirenz, like efavirenz, right, 3 Z's like that, that'll help you remember the fact that it has something to do with sleep-related stuff, aka nightmares. Alright? So that's really all you can do for that. The rest are pretty well named. Alright, so protease inhibitors all end in NAVIR. They are going to work by working on the assembly of virions, right? Because the assembly of virions depends on HIV-1 protease, which comes from the POL gene, right? Which cleaves the polypeptide products of HIV mRNA into their functional parts. Thus, protease inhibitors prevent maturation of new viruses. Right? And then they tell you ritonavir. Ritonavir can boost other drug concentrations by inhibiting cytochrome P450. It's the only one. All protease inhibitors don't affect P450, but ritonavir does. Alright, so you have to remember this one more medication for P450 upregulation. And if you don't remember it, then, none of the HIV therapy medications really do anything to P450. Alright, so if you ever get a question about HIV medications and their effect on P450, it's probably about upregulating P450. So at least remember that. It's not reducing P450 activity. Over here, then they go on to tell you nephropathy, hematuria, and thrombocytopenia can occur from indinavir as a side effect. Rifampin reduces protease inhibitor concentrations. So if you have to give rifampin, instead of using rifampin, which is actually going to upregulate P450 as well, use rifabutin. Rifabutin doesn't affect P450. Alright? So we talked about that when we were looking at the TB treatment medications. The other one here, your integrase inhibitors, right? These are the guys that inhibit HIV genome integration into your DNA, right? By inhibiting HIV integrase. This can elevate your creatine kinase, which it's not the most significant thing, but it's really the only thing they can test you on if they're going to give you a question on integrase inhibitors. And all integrase inhibitors have Tegra in it, so that's nice. Fusion inhibitors is another class of drugs that doesn't really work on HIV-2 very well as well. HIV-2 is intrinsically resistant to enfuvirtide. In addition, HIV-2 can utilize a broad range of co-receptors, such as all of these guys, so Malaria is not so therapeutic in HIV-2 infection. Right, but what do they do? So enfuvirtide, fuvirtide starts with an F, so this is going to use GP41. Right, 41 and fuvirtide both start with F, and it's for actual fusion. Fusion being the fact that it's actually combining the virion into the cell membrane. Malaria is for docking. Right, so it's an attachment thing, and it binds the CCR5 on T cells and monocytes, inhibiting interaction with GP120. So this is GP120. Right, and that's it. That finishes up all of microbiology. Not the hardest thing on earth. Definitely needs some repetition. I would go over it again before you go to sleep, or check it again tomorrow morning, and then come back to it another day maybe. But that's generally all there is to that. Hepatitis C is the last topic over here. Chronic HCV infection is treated with different combinations of the following drugs. None is approved as monotherapy, because remember, all the C's for hepatitis C, one of the C's was change. Right? It's constantly mutating because it doesn't have its own proofreading. It doesn't proofread itself, so it's always mutating. So you can't keep using the same medication. Now, these medications are really interesting because they weren't as significant. Let me see if they were in 2018, because they weren't always as significant. Yeah, see, in what do you call it? In 2018, it didn't look the way it does look now. Right? They mentioned the medications, but now they kind of changed around the way they ordered it. So you have your NS5A, NS5B, NS3, and then alternative drugs. For the 5A inhibitors, you have your ledipasvir and ombitosvir. Never really seen them in a question before. They inhibit NS5A, which is a viral phosphoprotein that plays a key role in RNA replication. Unknown exact mechanism. Great. Sofosbuvir I've seen. Sofosbuvir and salbuvir, therefore NS5B. So this is nice in the sense that usvir starts with an A. So this is NS5A. Buvir starts with a B. This is for NS5B. So it's not so hard to remember. This one inhibits NS5B, which is an RNA-dependent RNA polymerase acting as a chain terminator. Alright, so it prevents viral RNA replication. Sofosbuvir has been the answer choice in many questions. Then you have your NS3, and these are grasoprevir and cimiprevir, right, which neither starts with an A or B, so that's the only one that's going to be for number 3. Inhibits NS3, which is a viral protease, preventing viral replication. And now you have side effects. Grasoprevir has photosensitivity, which is a little less nonspecific than headache and fatigue, which pretty much can happen to anything. The alternative drug is ribavirin. Right, ribavirin inhibits the synthesis of guanine nucleotides by competitively inhibiting IMP dehydrogenase, used as adjunct in cases refractory to newer medications. Right, and they didn't mention the interferons, so let me read interferon from here. Interferons are glycoproteins normally synthesized by virus-infected cells, exhibiting a wide range of antiviral and antitumoral properties. Clinical use: chronic HBV and HCV, that's an error, Kaposi sarcoma, hairy cell leukemia, condyloma acuminatum, renal cell carcinoma, a bunch of stuff. You can use interferons for so many things. And in 2019, interferons are actually mentioned again later on. So that's probably why they skipped it over here. But definitely worth knowing, so make sure you do know it very well. Right? And then the rest of the stuff is very non-specific, not so important. You can just check it out on your own free time real quick. The disinfection and sterilization of things is very, this is a stupid thing that you can definitely get a question on. Worth spending time on for sure. You just need to know which ones are actually sporicidal. So ethylene oxide and hydrogen peroxide kill spores. The rest of them, they don't. Autoclaving is the main way we kill spores. But if you don't have autoclaving available, then ethylene oxide and hydrogen peroxide are the only other way to kill spores. The other things don't kill spore. Right? And then antimicrobials to avoid in pregnancy, obviously worth knowing. medications that are teratogenic or problematic for a pregnancy. Alright, so thank you for joining, thank you for sticking along. I hope that I've been able to help make microbiology slightly more easier by integrating not just Sketchy Micro but also Amboss and UWorld. And then now all of that is done. Do some practice questions for sure, obviously. Do, you know, whatever, if you need to use what do you call it, flashcards and stuff, go ahead and do that if you need that. I would say repetition is very key, so running down this really quickly one more time would be very helpful for sure. And then in the next video from here on, I'll see you guys and we'll do pathology, cellular injury.